Welcome. I am Sarah Ramaya, Curriculum Designer at ASRM. This webinar is jointly presented by the Society for Reproductive Technology and the American Society for Reproductive Medicine. The moderator of today's webinar is Dr. Mark Trolice. Dr. Trolice is the Director of Fertility Care, the IVF Center in Orlando, Florida, and Professor of Obstetrics and Gynecology at the University of Central Florida College of Medicine. He is board certified in REI and OBGYN and receives the AMA Physicians Recognition Award annually. His new book is The Fertility Doctor's Guide to Overcoming Infertility. This webinar was developed by SART and ASRM as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters at the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn the presentation over to Dr. Trolice.
Thank you, Sarah. Hello, everyone. And I want to give a special acknowledgement to Sarah Meyer for all of the effort that she has expended on putting all of this together. So thank you so much, Sarah. And good day to everyone. I am so excited to be moderating this vital topic that remains controversial after all of these years, more than 30 years since this has come into play. With us today are our two outstanding clinicians and researchers that we are all aware, Dr. Richard Paulson and Dr. Eric Forman. The topic today, PGT for aneuploidy, we're debating universal versus discretionary use. So the format is going to be, we're going to have an initial poll that will assess our current views from the audience on PGT-A. Then we'll go into a presentation by Dr. Paulson, followed by Dr. Forman, and bring it all together to have about a 5 or 10 minute debate, if you will, on PGT-A. At the end, we'll open it up to questions from all of you. So we look forward to a fantastic hour, and let's get started. Next slide, Sarah. So myself, nor any of the participants, we have nothing to disclose. Here we are with our poll. There are 5 questions, and Sarah is going to bring up each question, and we'll get instantaneous answers from the percentages of the audience participation. So the first one, do you recommend PGT-A? And those are the choices. All patients, only women above age 35, only for gender determination, or only for patient request. Please select one. Okay, and let's see what we have. So interesting. Where the majority of our participants seem to only be offering it to women above 35, which is consistent with the recent STAR trial. So very, very good. Next question. Do you think PGT-A is recommended for advanced paternal age patients? This is paternal age now. Okay, so a little bit more in favor of no at this point. And so some preliminary information is sort of coming through for some suggestions of doing it with advanced paternal age, but certainly nothing definitive. Do you advise CVS and amniocentesis following PGT-A pregnancies? Wow, interesting. We are essentially 50-50, right down the middle in terms of offering CVS and amniocentesis after a PGT pregnancy. All right, next. Do you currently transfer mosaic embryos? Another controversial areas. Yes, only low level. Yes, low and high level, or not at all. Okay, so not necessarily a convincing, but mostly low level of all of the answers. So somewhat expected. And would you ever transfer a known aneuploid embryo? So we're getting some tough questions here. Yes, or only through IRB protocol, or not at all. Okay, so not at all is the dominant answer there. And we're going to revisit this poll at the end of the presentations to see if there was some influence by our speakers and the discussion. So our first talk today is presented by Dr. Richard Paulson. He is going to be taking the con side, if you will. His talk is entitled PGT-A, a realistic assessment of benefits and costs. And we're always excited to have the insights of Dr. Paulson and after all of his contributions to our medical literature. Dr. Paulson.
All right. Well, thank you very much for the introduction, and and thank you again for inviting me and allowing me to participate in this seminar. It seems like yesterday that I was getting a little annoyed at what I was seeing around me with PGT-A being applied to every patient, and so I approached the people at the Pacific Coast Reproductive Society to allow me to debate Richard Scott. That was 4 years ago. I think I still have some of the same slides from 4 years ago that we used back then. The problem with PGT-A is not that there is anything wrong with the concept. On the contrary, I think the concept is very sound. And I think you will find that Dr. Forman and I agree that PGT-A is certainly applicable in many cases. And I think we can also agree that it is the future of assisted reproduction. The parts that you will see where we disagree is what is the realistic assessment of the costs and benefits in specific situations, particularly then when it comes to what is the real aneuploidy rate in certain populations, and how many embryos do you lose when you do this purification that I like to call it, which is PGT-A. What I mean by that is that you take your raw mixture, that's your untested embryos, and you subject it to some sort of purification, that's the PGT-A. And on the other side, you get a more purified sample, more gold per dirt, if you will, if you were out in the Yukon and you were collecting gold. And inevitably, when you go through a purification, there are losses. And I would suggest to all of you that those losses continue to be quite high. We do not know what the accurate, precise aneuploidy rate is, nor what exactly the losses are that are associated with PGT-A. I will foreshadow my conclusion, and that is that it's somewhere between 0 and about 50%, but it's certainly a lot more than people think. All right. That's the preamble. All right, the purpose is to understand the benefits and the intuitive appeal of PGT-A. We can all agree on that. I will now then try to describe the costs associated with a clinical application of PGT-A. And by costs, I mean losses of potential implantations, and therefore to counsel patients about the appropriate application of PGT-A, because sometimes those costs are worth it and other times they are not. So here's the intuitive appeal of PGT-A and some of the kinds of materials that got me started in this in the first place, because these are very real advertisements that you can find online. And it says right there, helping you have a successful pregnancy and a healthy baby. And right in the middle, it says PGT-A increases the chance of pregnancy. So that is a very nuanced kind of statement. But of course, that's not what you see with these smiling people who are all very happy to know that they've done everything they can to have the healthy baby that they want. So here's the benefit. The benefit is an increased pregnancy rate per transfer. So back to my metaphor of you being out in the Yukon and you come back with this bag of dirt that's 50% gold. And by that, I mean 50% implantation rate. The little gold nuggets, those are your embryos that are going to produce a live birth. And so if you look at the patients under 35, the control group is about 50%. And then according to this advertisement, in any event, you can go up to 65% if you just subject the embryos to this purification. So you come back from the Yukon and you say, well, I got a 50% gold bag. Can you increase it to 65%? And the guy says, yes. So that's great. Is that all you're going to ask? Or are you going to ask, well, wait a minute, how much am I going to lose? And this is the part that is not quite as intuitive numerically, but look at that, 52% aneuploidy rate. I will show you how if you throw away 52% of the embryos at the beginning, and remember that the implantation rate in the control group was 50%. So I had a 50% and I'm going to throw away 50%. I should have a much greater percentage of purity than 65%. But I'm getting ahead of myself, and Dr. Forman actually is going to present some of that mathematics that I am so fond of. So that's the cost of PGT-A. Those are the losses. How do you lose embryos? Well, you lose them from two reasons. Number one, you have a false positive result. You throw away the embryo. It turns out that it was normal. You should have transferred it. That's a loss. Or you have a normal embryo. You think it's normal and you transfer it, but the embryo now does not implant at the rate that it would have had you not done the biopsy, because there was damage to the embryo due to the trophectoderm biopsy. And we're all probably getting a little bit better at this. We're doing the biopsies later. We're waiting until the embryos are more expanded. I think they're also doing a better job of being atraumatic during the biopsy. All right, so latest data, we all know about it. It's right here, and there's going to be a journal club next week about it with Richard Scott. This is one of his studies, multi-center prospective blinded non-selection study evaluating the predictive value of an aneuploid diagnosis using targeted next-gen sequencing-based preimplantation genetic testing for aneuploidy assay and impact of biopsy. That's the title, not the abstract. But here's the graphic from that. And if I just direct your attention down to the bottom, PGT-A euploid transfer is 312 and 102. Remember, these were non-selection. So they took a bunch of embryos, they biopsied them, they transferred them, and in fact, they transferred 484 embryos. And then afterwards looked at whether they implanted or not, and were they or were they not tested as euploid or aneuploid. So first thing you notice is that 312 and 102 adds up to about 414. That's not exactly 484. So there was a bunch that were sort of intermediate results. But in any event, when they said it's euploid, they had really high implantation rates, and live birth was about 2/3, 200 out of 300, and absolutely miraculously and astonishingly and unprecedentedly, of the 102 aneuploid transfers, there was zero live birth, zero ongoing implantation rate. Here's a great graphic. The euploid ones are up at the top. Remember, that's only in retrospect. It's not like they're transferring euploids. They're transferring all the embryo. And 82% implanted, and 73% were clinical pregnancy, and 65%, about 2/3, went on to be sustained implantation or delivery, whereas the ones that were aneuploid, actually, interestingly, they had an awfully high positive serum beta HCG. I'm not sure how to deal with that, but in any event, 0% sustained implantation and delivery. Then so that shows you that there's 0 false positives in this study. 0 false positives, none. What about damage from embryo? They said, well, if you look at the study group overall, the sustained implantation rate is about 48%. That includes euploids and aneuploids. And our control group that was not biopsied has about the same implantation rate. That's a little low, I think, 45%, to be honest with you. But in any event, taking that information at face value, 0% decrease in implantation rate as a result of the biopsy. So this study showed, and this, by the way, just confirms the previous study from Richard Scott. Everyone on this webinar, I'm sure, has seen this study before. Shows no decrease in implantation rates when the blastocysts are biopsied. The difference here was that this was a fresh embryo transfer within 3 hours of the biopsy. All of the embryos with 4AA and 4BB, and whereas in the current study that I was just showing you, they were all frozen. So this would sort of undermine this whole concept of cost of PGT-A. This says that there is no cost to PGT-A, because I said that it's either false positive results or damage due to the embryo, and they showed, let's see, false positive results 0, and damage to the embryo 0. So this would really imply that it's just perfect. I would point out that the aneuploidy rate in this study was about 25%, maybe even a little bit less. So that also is unprecedented. And so I want to contrast it with the START trial. And remember, I said at the beginning that the losses are somewhere between 0 and 50%. So that was a study that showed 0% losses. And that would be another way of saying it, if you like, the efficacy, efficiency, and effectiveness kind of a model of medical procedures. That was the efficacy. So the efficacy says if you take a perfect situation, perfect group of patients, idealized situation, you can demonstrate an increase in implantation rates and actually 0 losses. So the START trial has been previously reviewed. Remember, this was a multi-center trial that was put together by Illumina that had a new gizmo, very-seq PGS, and new next-gen sequencing solution. And this is what they found in the control group and the PGS group. The control group had a 50% implantation rate. You saw that previously in that advertisement that I showed you. And after PGS, instead of there being an increase, unfortunately, it stayed about the same. The only place where they did get the increase was in the group over 35, where the control group now had a lower implantation rate, and they went up to 50%. And I'll gloss over the fact that they didn't have a difference in miscarriages. This is kind of an unusual feature of this database. But the aneuploidy rate in the patients under 35 was 50%, 49.3, okay, close enough, 50%. So now you don't need to do math. You can just use logic and intuition. And if I tell you that I had a 50% implantation before you went through the purification, and then after the purification, you still have a 50% implantation rate, and I took half of your material away for aneuploidy, how many potential implantations did you lose? So go back to your Yukon. I came back from the Yukon and I got 2 bags. Each one of them has a kilo of stuff in it, and there's 50% gold in each of the bags. So I got 2 kilos, 50% gold. I have 1 kilo of gold. And you say, well, I'm going to do this purification for you, but it's going to cost you half because aneuploidy rate is 50%. So half of the bags are going to be gone. I'm going to give you back 1 bag, and that bag purification is 50%. So now I have 1 kilo and half of it is gold. So what did I lose? I went from 1 kilo of gold to half a kilo of gold. I lost 50%, and that is what the STAR trial shows. And Eric will show you the math, which I'm so pleased that he read my math paper, and here it is. But not to belabor the point, the loss of implantations in the STAR trial is 50%. So that's much higher than what you just saw, right? And of course, you can't say that it's due to false positives or damage to the embryo. You don't know. It's a combination of those two. So we don't know, but it's about 50% loss, and that's the problem. And back to this concept, efficacy, capacity of a given intervention under ideal or controlled conditions. Yes, PGT-A has efficacy. You just saw it in Richard Scott's study. Is it effective in the ability of the intervention to have a meaningful effect in patients in normal clinical conditions? Yeah, I would say that's closer to the STAR trial, right? Because it does actually increase implantation rates in the patients over 35. Is it efficient, doing things in the most economical way? Well, how often would you be willing to pay 50% to have that increase in the implantation rate? So it's efficacious, it's effective, increases implantation. It's not efficient. The losses are 0 to 50%. So you say, well, I'm not sure I believe that. What's a more realistic number? Okay, what about 25%? I'll grant you that maybe it's 25%. So it's useful in that group of 35 to 40 with many blastocysts. In fact, if you have many blastocysts, then I would argue that yes, PGT-A is useful. If you're 41 and you have 10 blastocysts, by gosh, you should be doing PGT-A. But we don't have those patients in California. I think must be an East Coast phenomenon. Most of the patients that I have that are 41 years old have maybe 4 or 5 eggs, not 4 or 5 blastocysts. PGT-A is unnecessary in young, good prognosis patients, but likely no harm. If you've got, again, 10 blastocysts in a donor egg situation, You're not gonna, that's not much harm if you're losing 20 or 30% of potential implantations. But PGT-A is definitely harmful in a fertility preservation patient with limited eggs. I just want to cry when they come here to the office and they say, I froze my eggs before cancer and now I'm a cancer survivor. And I went to program X and they thawed my 10 eggs and they ICSI'd them and they grew them to blastocysts and they said only 3 made it to blastocysts. And then they did PGT-A and one's non-diagnostic and one is euploid and they transferred it and I had a miscarriage. I mean, that is not doing that patient any favors. And older poor prognosis patients, well, poor prognosis, the 4 or 5 eggs like we have here in California, yeah, if you're going to try to grow those to blastocysts, why bother? You're going to do 3 cycles and you're going to say, well, you didn't have any blastocysts, so we're not going to transfer any of those. That's I think, not doing anybody any favors. So that's it. Thank you.
Thank you, Dr. Paulson. Always compelling and thorough review of the literature. We switch now to Dr. Forman. Dr. Eric Forman is going to be speaking on PGT-A, the case for universal use, so more of the pro side. So, Dr. Forman?
Thank you, Dr. Trolice and Sarah for inviting me, and thank you, Dr. Paulson, for that excellent preview presentation. And I have to say, I've been following Dr. Paulson for a while. I've seen his prior debates, and it's definitely a tough act to follow. But I think there is a different way to look at this real-world data, and stay tuned. So my goals are to discuss some of the rationale for why PGT-A was developed in the first place, and what appropriate validation of this technology might be both before use and then in clinical practice, and to discuss some of the data supporting universal PGT-A as a method to enhance selection for single embryo transfer. One thing that you didn't hear at all in Dr. Paulson's presentation, and Dr. Paulson served as the president of ASRM, which has been touting single embryo transfer for many years as a way to improve the safety of this field, is that this is the path to universal single embryo transfer. And then discuss some appropriate candidates, and I hope to discuss some of this with Dr. Paulson at the end. So I think a lot of this comes down to what is the goal of IVF? Why are we doing this? Is it, as I call now, the Paulson doctrine, which he just kind of hinted at? He's written in Fertility and Sterility that we should be trying to get every last baby out of every last egg. Is that really the goal? Do we really expect to get every baby out of every egg? You just said, that patients sometimes have many embryos and don't transfer all of those. What is the cost of potentially transferring all those embryos? So that patient who Dr. Paulson just said wouldn't make a blastocyst and transferred fresh, if she goes through miscarriage, if she has an ongoing aneuploid pregnancy, did he help her with those transfers? And we know that there's good data that for women over age 40, it's not an insignificant proportion that will have an ongoing aneuploid pregnancy and have to face a difficult decision of termination or having an abnormal pregnancy, either of which would set them back many months, sometimes a year, in terms of trying again. So this kind of setback is never brought up in Dr. Paulson's presentations. Also, Dr. Paulson has argued very eloquently that we shouldn't really think of eggs or even preconception, pre-implantation embryos as babies. We're not getting babies out of eggs. These are potential. And so in the prior administration, there was a movement towards saying life begins at conception, and he very eloquently argued that this was a flawed concept, and we should not be saying that life begins at conception. So an egg doesn't necessarily translate to an embryo, doesn't necessarily translate to a baby. Our goal is really to help individuals or couples achieve their desired family size, one healthy, hopefully full-term baby at a time. So not to give them triplets by putting back 3 embryos and having them lose that pregnancy, not to give them an aneuploid pregnancy, but to have a healthy full-term baby one at a time. And in so doing, we want to minimize the emotional stress from failed cycles, from miscarriages, from terminations, We want to minimize the risk of treatment, so this is a separate topic, but we've done a great job in this field of basically eliminating the risk of ovarian hyperstimulation with GnRH agonist triggers with freeze-all approach, multiple gestation, which are higher risk for moms and babies, and pregnancy complications. And there's a move towards improved pregnancy outcomes with frozen embryo transfers, maybe natural cycle frozen embryo transfers. And we'd like to minimize the treatment burden. So cost, if this technology adds cost, that's a burden. If multiple cycles, more cycles are required, that's a burden as well. We have to balance, these two sides of it. Again, our goal is one embryo, one healthy baby. So what is the goal of PGT-A? Why did we develop this in the first place? Well, whole chromosome aneuploidy is a problem. It is the cause of failed implantation and early miscarriages. It increases with increasing maternal age primarily, not so much paternal age per the quiz question. I don't think this is debatable. Dr. Paulson would agree with this. There's no evidence that IVF pregnancies are at a higher risk of whole chromosome mosaicism, segmental mosaicism, or full segmental aneuploidies compared with unassisted conception. And there's nice studies looking at large populations on this. So we're not generating more mosaic pregnancies. Most embryos are either fully normal or fully abnormal. You hear a lot of talk that every embryo is mosaic. I don't think there's evidence to support that. There are mosaic embryos, there are mosaic people, but it's likely a very small percentage and has a debatable clinical impact. There are biopsies that get an intermediate copy number result after PGT-A that many labs call mosaic, and Dr. Paulson has also eloquently argued against this terminology, but that intermediate copy number does not prove the presence of abnormal cells, and much less a low level, a high level, the number of abnormal cells. That's a lot of inference without a lot of data. So I thought he was going to show a soccer ball. He's shown a soccer ball before. He's argued that embryos are like soccer balls and we could just be plucking cells from this black area, which is abnormal or mosaic, and we're not really getting the full representation. But most embryos are not soccer balls. They're the same color panels. So I think it's important when looking at these different type of studies to realize these are different technologies. I'm going to show some studies that used real-time PCR. Dr. Paulson showed a study using whole genome amplification and next generation sequencing. He also showed one using a targeted sequencing. Nathan Treff's team did a nice review of different studies that looked at reanalyzing embryos, whether they were originally called abnormal, biopsies were taken from that same embryo and reanalyzed, or if they were called normal or they were called mosaic. And you could see in the middle the original biopsy, and then if it was fully aneuploided, what did the repeat biopsy show? If it was fully euploid, what did the repeat biopsy? If it was mosaic, what did it show? And again, these discrepancies are higher than I would like, but the vast majority confirm the original whole chromosome aneuploidy or euploidy, but the mosaic result is kind of a mixed bag, showing that diagnosis is very controversial and doesn't really correlate with clinical outcomes. Interesting, the studies that were more binary, not calling mosaicism, not using next generation sequencing, which came along and appeared in many ways to be better, but also complicated the results. Those studies have a higher concordance between the repeat biopsies. So not all assays are the same. It's a clinical test. If you're ordering it, you should know what the lab uses and how it was validated. We now have good data that this technology can work and can improve implantation rates and even live birth rates. And this is a meta-analysis of 3 different studies. None of these studies actually use next generation sequencing. None of them reported mosaicism, and they were all done quite a while ago at this point. So the RCTs in this meta-analysis, to be fair, they all included good prognosis patients, 17 to 19 eggs. Most of them biopsied embryos on day 5. And these were single centers, very experienced, mostly fresh transfers. They were using rapid technology like PCR, and only reporting whole chromosome aneuploidy. This did not involve mosaicism. So going to the STAR trial, which was already shown, so I'll go quickly here. Interestingly, 13% of the patients had no blastocyst to transfer, not no blastocyst at all. 60% of those had at least one quote-unquote mosaic embryo that was not eligible for transfer. So how would the results have changed, again, if instead of this purification method that Dr. Paulson mentioned, some of those that didn't make it through the purification process, many of us would transfer, as shown by the poll. And this, again, just, I would say there's something, concerning with an average age of 33 if fewer than half of the embryos were normal. I agree. And 17% were mosaic. And I mentioned in the beginning, that there's not an increased risk of mosaicism in IVF pregnancies and babies born from IVF. Something like 1% have true mosaicism. So this seems like an overdiagnosis, and these embryos were not eligible for transfer in this study design, even though we know they can make babies. Going back to this study, one of the ones in the meta-analysis, the average age of patients was higher, was 35 versus 33.7, and 69% of the blastocysts were euploid. Older age and significantly more were transferable compared to the STAR trial. So you have to be concerned with the assay and the criteria that are being used for what's eligible for transfer. And we see that also in large studies looking at clinical experience. Here, one center, 15,000 plus blastocysts tested. This is the aneuploidy rate on the y-axis, and you can see that more than 60% of embryos are normal, even up to age 37. And remember, he was saying that under age 35, it was maybe 60%. But another large center with their assay and their technology actually, the euploidy rate, they flip the y-axis. They're looking at the proportion that are euploid. Fewer than 60% are euploid even under age 35. So this is a discrepancy. Now some might say, oh, our patients are more difficult prognosis. They've had miscarriages, they've had failed implantation. Really, that's probably not relevant. Age is the only, consistently in many different studies, age is the only factor that influences the aneuploidy rate. This was a large study from a PGT lab looking at clinical parameters, and there was no association with prior reproductive history, prior IVF cycles, miscarriage, even presence or absence of normal embryos in prior cycles. So it all comes down to age. So if one center's aneuploidy rate is significantly, or a proportion of embryos that are transferable is significantly different than another's, and the age of the patients is similar, that is an issue. And we've seen this slide already, this blinded non-selection style. I think this hammers home that transferring aneuploid embryos is not benign. And I agree with Dr. Paulson. He was, I think, concerned that 0%. I don't think the authors stated that an aneuploid embryo would never implant, but the confidence interval may go to 2-3%. So a small percentage probably would make a baby, but also you're preventing a lot of miscarriages. So rather than look at advertised rates from years ago, and I think if this is a test that you're using, and most IVF centers are using PGT, I think you should look at your own lab and your own rates. What proportion of embryos have whole chromosome aneuploidy? It should be around 20% in the under age 35 group, looking at this recent data. An implantation rate of euploid embryos should be somewhere from 55 to 65%. So if a much higher proportion are aneuploid, that is concerning. That suggests maybe this purification process is not is too vigorous and you are losing some normal embryos. Also, if your euploid embryos are not performing well, maybe there is a problem with your biopsy technique. How do you validate this? Consider blinded rebiopsies. So PGT labs should be open to accepting rebiopsies of embryos that are donated to research, and you should get consistent results. Again, if aneuploidy originates from a meiotic error in the egg, and every cell downstream inherits that abnormality, then a full aneuploid embryo should have the same result on repeat biopsy the vast majority of the time. And if fewer than 60% of embryos are transferable under age 35, I agree with Dr. Paulson, we probably shouldn't be doing PGT in that setting. At our center, using a couple of different labs, 98% of the time we get a result. So sometimes we don't get a result, then we have the option to transfer or rebiopsy. In patients under age 35, 20% have whole chromosome aneuploidy, and 3% have segmental aneuploidy, and nearly 80% of blastocysts are transferable, many more than that 50 to 60% you previously were shown. I also think it's overlooked that when these studies look at aneuploidy rate, they're looking at all the embryos, the whole entire cohort. So I look back years ago at a selection of 100 consecutive embryo transfers and said, the first embryo, the one that's selected for single embryo transfer, is that random? Is there a relationship between morphology and ploidy? There is. It's just not reliable enough to say the best embryo is always normal. But actually, the quote unquote best embryo is a little bit more likely and significantly so in older patients to be aneuploid. I mean, to be euploid. So let's go to Dr. Paulson's math. Where does he get this 20 or 0 to 50% loss? He looks at the idealized implantation rate. If you have your implantation rate of your unscreened embryos and you have some underlying normal proportion, again, you should improve that when you screen out the abnormal embryos. And this is a calculation he used in one of his papers where he said 50% of untested embryos make babies when transferred under age 35. 60% are normal. Again, I think that's an underestimate. You should have an 83% implantation, but if you use a 67% implantation, which is generous, you lose 20% of your embryos, 20 to 40% using different estimates. But in reality, if, again, 77 or 80% of embryos are actually transferable under age 35 when using a reliable, validated technology, and probably more than that if you're looking at the best embryo of the cohort, 85%. And I agree, about 50% untested, at least in frozen embryo transfer, maybe not fresh. You should get actually about a 59% implantation rate. In our practice, we have a 57% live birth rate when we transfer a normal embryo. So dividing that, we get 0.97 for the efficiency, maybe 3% are lost. And again, I think there's a lot of assumptions built in here. The populations are different. That's kind of margin of error. So there may be some loss. It's not nearly 50%. If it is, I agree, we probably shouldn't be doing this. So let's be honest and also look at other interventions in the IVF field. Dr. Paulson estimated 20 to 40%, maybe as high as 50% of implantations are lost by PGT-A, but then in the same breath suggested we should just be putting embryos back into this fresh, hyperstimulated endometrium, which is not ideal. So there was a large multi-center trial from China that looked at the approach of freeze-all versus fresh single blastocyst transfer in young patients, and 39% in the fresh went on to live birth, whereas 56% in the frozen went on to live birth. If you do the efficiency here, you get 0.7, so nearly 30% of implantations would be lost by routinely doing single blastocyst transfer. does Dr. Paulson recommend that we do freeze-all for all young patients planning single blastocyst transfer? Those lost implantations seem significantly more than PGT. Again, maybe you would argue if you have a lot of embryos, you can afford to lose some to save some time. That's another debate. But I think we should be honest about other interventions. And in practice, we don't see this loss. If even in older patients, this nice study from Italy, patients even 44, when they made a normal embryo, 57%. So these would be the most fragile embryos to biopsy, and they perform just about as well. But how many abnormal pregnancies, miscarriages, terminations were prevented in the process? And finally, I think we've, again, glossed over maybe the biggest benefit of PGT-A, which is universal single embryo transfer. We now all agree that if you have normal embryo, you should transfer one at a time. And this is now being seen finally in real world data. At our center last year, more than 97%, now it's over 99% after PGT have single embryo transfer. And across the board, 77%. The most recent SART data in 2018, 75% of all transfers were ESET. It's probably higher now. What might explain that? Why in 2005, a measly 9% of transfers had a single embryo? Most of those were probably non-elective. Maybe they only had one embryo to transfer. By 2010, it budged just a little bit to 15%, but you can go back and find recommendations touting single embryo transfer. By 2016, it jumped significantly to 40%, and again, now we're over 75%. I think this is mostly attributable to PGT-A and having the ability to convince doctors and patients and embryologists to transfer one embryo at a time in the real world when it's normal. So who should use it? When using a safe biopsy technique and a validated PGT assay, it's reasonable to offer it to all patients. As I said, if it's efficient, if there's not significant losses, it's reasonable. And single embryo transfer should be mandatory for at least the first transfer. So young patients, they benefit from doing freeze-all anyway, from that trial in Lancet. And again, a very high proportion of the best quality blastocysts are going to be normal. So you would need a huge trial to show a significant benefit when you have such an underlying high euploidy rate. And not everyone under age 35 is the same. So just calling less than 35, that can vary. If in one study, a lot of those patients are in their late 20s versus 33, 34, aneuploidy rate increases. But also, again, we're not just looking at having a pregnancy, having a delivery, having a preterm twin delivery. Many of our patients want more than one child, and we want to help them have it one at a time. It's helpful to know the potential of the other embryos frozen. For patients over 35, we now have several studies showing higher live birth rate per transfer. Again, for those desiring more than one child, some of those 40-year-olds, even in California, might want more than one child. It may be difficult, but if they can do multiple cycles and know that they have multiple viable embryos, that can help them plan when to stop or when to keep accruing embryos. Donor egg, it's not proven to be beneficial. I don't think it's proven to be harmful. If there's a lot of embryos, if there's a prior history of miscarriage, again, it's reasonable to offer. Recurrent loss population, we don't have prospective data, but reasonable to expect it reduces loss rate. And are these embryos truly lost anyway? I think there's a change in the last few years that many clinics don't automatically discard abnormal embryos, and quote unquote mosaic embryos or intermediate copy number, they can make healthy live births. And even a recent review, in some situations, depending on the day and the grade, they might do better than some euploid embryos, and they should not be discarded or lost. And aneuploid embryos, some centers are transferring them. There's an ongoing trial out of Stanford. If your clinic is not comfortable transferring them, you can transport them to another clinic. So we shouldn't automatically discard embryos. They aren't lost. And I think this is another approach to PGT where the harm potentially is minimized. So in conclusion, we've moved beyond the days of just putting back a bunch of embryos on day 3 and seeing what sticks. Freeze-all and elective single embryo transfer eliminates many of the treatment-related risks like hyperstimulation and multiples. Universal elective single embryo transfer, it's not only possible, it's happening, and centers are doing it well over 90% of the time. That's unprecedented. Some patients won't have a transfer, but we'll also avoid futile transfers, some losses, terminations, and aneuploid deliveries. And transfer of aneuploid embryos can be considered as a last resort for those patients who are not able to make euploid or fail with their euploid embryos. Thank you.
Thank you, Dr. Forman, for that thorough review and your interpretation of the literature for PGT. Before we go further, I just wanted to not be remiss and formally introduce our panelists today. Dr. Paulson is the director of USC Fertility and has been with the practice since 1986. He is also a professor of obstetrics and gynecology and chief of the Division of Reproductive Endocrinology and Infertility at the University of Southern California Keck School of Medicine. Dr. Forman is the medical and laboratory director at Columbia University Fertility Center. He oversees the medical practice as well as the IVF embryology and andrology laboratories as their HCLD. He also actively sees patients with infertility and those seeking to preserve their fertility, has extensive clinical and laboratory research experience, and has published more than 40 articles in peer-reviewed journals on a wide range of topics in ART. So thank you both again for just outstanding review and discussion. Before we get to the many questions that are chomping at the bit to get answered, I wanted to just mention the STAR trial because you both had referenced that, and I agree with the concern about the aneuploidy rate. The assay genetic platform was not validated through non-selection and looking at false positives. So I think that there is certainly some question there. Let me bring up an issue that we haven't talked about. Do we have a handle on really the concordance comparing trophectoderm and inner cell mass? What are we telling our patients, and what is our interpretation of the literature? Dr. Paulson?
Well, we don't know. That's the point, right? So I agree with Eric. I mean, we have to keep, it's great. You got to keep doing it. You're not going to be able to set up, the NIH is not going to fund a large prospective trial of 100,000 cycles where you're going to biopsy the inner cell mass and the trophectoderm to see what the concordance is. So we're going to have to get little pieces of data as they come along. And Mark, you mentioned the aneuploidy rate in the STAR trial, but I have to tell you that is, I don't know. In fact, my question for Eric is going to be, where do I have to go to get a 15% aneuploidy rate or even a 20% aneuploidy rate? Because the 50% aneuploidy rate in women under 35 is not just in the STAR trial, not just in the advertisement from eGenomics, which, by the way, they agree with one another. The advertised stuff that Reprogenetics used to have before it became Cooper, and then they pulled all of this stuff so that people wouldn't take pot shots at them. People like me wouldn't take pot shots at them. It's always 50% aneuploidy in women under 35. And I would like to know what I have to do to get a 15% or a 25% aneuploidy, because that is very, very, very different from what is out there in the literature, very different from what was in the meta-analysis that you quoted, which had 40 to 50% aneuploidy rates. That was the aneuploidy rate. I would argue that that is the aneuploidy rate that is currently accepted as the standard in the community. What do I have to do? Is it a different mechanism, a different machinery? How do I get a 15 to 20% aneuploidy rate in my patients under 35?
I mean, I think it's hard to speak for these, there's a lot of different labs, and I mean, I think that would be a good topic or a good journal club to have labs present more recent data. That advertisement, I think some of those numbers include mosaic embryos as aneuploid. Some clinics, again, this is complicated to explain even amongst us and then to patients. it's easier to just say, I don't want to deal with that mosaic, just call it abnormal and we don't transfer it. And there are clinics that opt for that. And again, I think that I agree, does a disservice because it limits the number of embryos you might transfer. So I think that some of that older advertised data lumps together mosaic aneuploid as aneuploid. I mean, this recent non-selection study, that's a nonprofit foundation that they accept samples from other clinics, and I think they see similar aneuploidy rates regardless of clinic. Even in iGenomics, I think in more recent publications have aneuploidy rates that are much lower than 40–50% among less than age 35. So I think there are labs out there, and again, I look at our own data. Like I said, I think you can look at your own patients who are doing PGT-A and see what kind of aneuploidy rates you get. But I agree, if it's 50% under age 35, that doesn't make biological sense, too high, and either you shouldn't be doing it or you should find a different lab. Or look at your technique, work with the lab and say, hey, is this what you're getting from other IVF centers? Are we doing something wrong with how we biopsy or load? But that doesn't make sense.
But you saw
same
that
thing for egg donors. Same
right?
thing for egg donors.
Yeah.
And again, I think in the STAR trial, yes, there was a unacceptably high aneuploidy rate and a very high mosaic rate, and those mosaic embryos were not eligible for transfer. So even in the STAR trial, if that 17% had been eligible for transfer, some of those patients would have had transfer, some of them would have had live birth, and again, the final live birth rate per randomized patient might have been improved in the PGT group. So again, you have to go into it. You have to go into it being willing to transfer a mosaic intermediate copy number if there aren't euploid embryos available.
So there is some discrepancy over what is the true aneuploidy rate. Dr. Forman, in your presentation, you talked about that if everybody goes to the blastocyst stage to get biopsy, we're going to be missing some transfers. Patients are not going to be able to get a transfer. Dr. Paulson, what factor into the cost of PGT is the blast or bust approach that Glenn Chapman had talked about? What factor do you feel that is playing into the cost of PGT?
Yes, well, that is so complicated and that is completely unstated, and thank you for pointing that out, but I have not factored that in at all because we don't have that information. But the fertility preservation patient that I tried to bring up as an example, if you try to grow her embryos to blastocyst and she doesn't grow any blastocysts, and you say, well, you didn't make any blastocysts, so that's it, so you're out of luck. I feel that that's a disservice. And we don't, the problem with it is we keep extrapolating data like Richard Scott's last study. And that's a great study. Hats off to him, hats off. I mean, that's an amazing piece of work. But you cannot extrapolate from that to poor prognosis patients. You can't extrapolate from that to frozen eggs. Where's the frozen egg data? If somebody preserves their fertility because they were a cancer patient 5 years ago, barely get through the stimulation, you barely have some eggs, and you say, oh no, those are eggs. We're going to take those to blastocyst. Blastocyst or bust. You didn't make a blastocyst, or you didn't make a 4AA blastocyst. So now when you do the biopsy on that 1AA or 1CC blastocyst that might have done fine had you transferred it as a day 3, you're going to have crappy results, crappy outcomes, and so on. It's really, let me make one quick point. It's very interesting to me that insurance companies that are starting to cover infertility cover PGT-A. And the reason they cover PGT-A is because I agree with Dr. Forman, there is no more effective way to get doctors to do ESET other than PGT-A. And that's what insurance companies want. They want to save money. So they want to pay for the PGT-A, which will avoid multiple gestations, which avoids the very high cost of obstetrical delivery. Makes sense. By the way, if the patient doesn't get pregnant, the insurance company also doesn't have to pay. So if the PGT-A, which requires blastocyst or bust, which requires a euploid blastocyst, if that doesn't happen to turn out to have an embryo, the patient doesn't get pregnant, the insurance company also saves money. So just remember that what is in the best interest of insurance companies and cost of medical care is not necessarily the thing that is in the best interest of the patient. Sorry, I didn't mean to go.
So no, that's fine. So before we get into the questions, can we summarize both sides who you feel, since PGT is here to stay, of course, who is going to be the best patient served by PGT-A? Dr. Forman?
I mean, I think we agree on that the best candidate is the older patient who has selection, you know, that if you have, and there are patients like that. Again, I agree there are not many, but there are patients that make maybe not 10, 5, 6 blastocysts. It could take a long time to transfer those 1 or 2 at a time, and it could take a while to recover from abnormal pregnancies, and it's more efficient. But I think, again, I think it all goes back to counseling. So even the fertility preservation patient, and I've seen this again, I think if you talk to them, there are some patients that are terrified of having an abnormal pregnancy, a miscarriage. And again, if you give them the data and you give them the facts, let them choose. If your priority is to have a transfer, then I agree with Dr. Paulson, you know, thaw the eggs, make the embryos, transfer day 3 embryos. If, again, some patients will want to minimize the risk of abnormal pregnancy. And I don't think it's, again, for us to decide that's so I don't have a blanket statement that all patients thawing their previously preserved eggs should test or that none should test. I think it depends. And I've, in my own practice, seen that. I've had patients who did multiple day 3 transfers and went through abnormal pregnancies and finally had a baby. And I've had patients who grew to blast, and you know, there was definitely that purification process. Again, some of them don't get pregnant. Again, some of those patients who transfer those day 3 embryos don't get pregnant, and again, we could wonder, would they have done better at blastocyst? Would they have made blastocyst? Who knows? So again, I think it's all about counseling. It's a technology that's available. It can, again, basically eliminate the risk of ongoing aneuploid pregnancies, which we still see those. And again, I think they're difficult to go through, and some patients don't recover or take many months to come back and lose important reproductive time. So I think it should be offered to everybody, but some patients benefit more from it. Whether any patients are harmed by it, I think is debatable. It depends on the lab and the technology being used.
Dr. Paulson?
Yeah, that's it. You have to have a lot of blastocysts. If you don't have a lot of blastocysts, then no. So by definition, if you have 10 frozen eggs, you're not going to have a lot of blastocysts. I think that's a bad idea. If you're over 40 and you've got 4 or 5 eggs, of which 2 or 3 fertilize, you're not going to make blastocysts. So that's a bad idea. The problem is the universal application. And I agree with Dr. Forman. As long as you individualize and you do it that way, you're going to be fine. But there's a lot of practices right here in Southern California. You go in there, it's freeze all, PGT-A all, 100%, 100%, doesn't matter. And so those patients come to us and they say, hey, I'm 41 and I made 5, 6 eggs every time. And they told me that I had 2 blastocysts after 3 retrievals. They were both aneuploid and they said, I'm done, I need egg donation. Is that really true? That's the kind of group that needs to be randomized to day 3 transfer, leave me alone, and blastocyst or bust. Doing day 3 versus blastocyst RCTs on 35-year-olds is useless. But this kind of poor prognosis group, I would argue that we should not have so much faith in the degree of development that ART has achieved. And it's a lot better now than it was in 1986, I assure you, but it's not perfect. And I hope that in another 10 or 20 years, we'll be that much smarter and say, that was probably not the smartest thing.
Excellent to both of you. We have a question from Dr. Karen Hammond to both of you. If you agree that PGT-A is appropriate for women who have many blasts, why are these women being so aggressively stimulated?
Well, I mean, I think I don't know if they are being aggressively stimulated, but I mean, I think again, if they're in an older age group, the aneuploidy rate rises, and you need more eggs and more embryos to make embryos that could potentially make a baby. And if they want more than one baby, you can freeze and use those other embryos later. So I don't think there's evidence that milder stimulation improves quality or reduces aneuploidy. So so I think it's, again, I mean, it's there's an evolving field, but I think there's ways to safely stimulate and get a good number of eggs and a good number of embryos. But I don't really practice minimal stimulation.
Yeah, I do. I mean, I like it, but I agree with everything Eric said. There's no evidence that mild stimulation improves ploidy or any of those things. And I don't know that it's necessarily, Karen, that they're being so aggressively stimulated. They're just being stimulated. The follicle count is what the follicle count is. I have seen a couple of patients that were truly ridiculously overstimulated, in the sense that they had high AMH levels and they still give 450 of gonadotropids, and they grow very quickly. They have 14, 16 millimeter follicles on day 5, and they're being aspirated early, and you don't get a very good egg yield. That's dumb, but that's just self-defeating. But so it's not necessarily that they're being so aggressively stimulated. I think if you over aggressively stimulate, you'll actually shoot yourself in the foot, and you'll have fewer eggs than you would have had otherwise.
Yeah.
So,
this is an interesting question. What percentage of embryos that do not make it to blast are genetically normal?
yeah, I don't know that we can extrapolate. I don't know that there's enough data. You'd have to go back to the day 3 biopsies, and then we would be here for another 8 hours discussing that. I don't know that we know that. I don't know that we know.
Yeah.
I think there is some selection, that, but again, not enough to rely on. But I think the embryos that make it to blast, I think there are some studies that they're a little bit higher euploidy rate than all of them.
Mm-hmm.
But there are some normal embryos that stop developing for other reasons. And as we know, obviously, aneuploid embryos can go all the way to implantation.
You have to remember that the DNA, right? The DNA is not being transcribed until you get to 8-cell stage. And then even if you're transcribing the DNA, how much of that DNA do you actually need to get from 8-cell to blastocyst or to make trophectoderm? My point always has been, and one of the reasons that I was so enamored of the soccer ball analogy, which I agree is not perfect, is the idea that the trophectoderm doesn't really care if it's euploid or not. You care if the fetus, the inner cell mass, is euploid. That's important. But trophectoderm, who cares? It's a placenta. If it's triploid or whatever it is, or trisomic, nobody cares. So it needs to divide very quickly. Why would it not make lots of mistakes? It should make lots of mistakes, and it probably does. And that's probably where we get the intermediate copy number, which, by the way, I'm glad that Eric and I agree it should be called intermediate copy number, and let's stop calling it mosaic.
We have a question from Dr. David Adamson. Many claims are made for PGT based on live birth per transfer. What is needed is live birth per intention to treat, obviously, as in the STAR, right? Let me see if this gets to a question. It's really more of a comment than it actually is a question. Despite live birth per transfer, overall live birth per patient has not been increasing since PGT was introduced, and continued research is needed in that area. So thank you, Dr. Adamson. Before we go to the poll, I thought that we would give an opportunity to pick one point of each other that we wanted to counter or refute. I know that there is a lot of common ground, but is there one aspect that is really pressing on both of you, countering the other? Dr. Forman?
I mean, I would counter this point that, that the patient with only 2 embryos doesn't make blastocyst. I think it's hard to predict, how embryos are going to develop in a high quality modern ART lab. And there are 40-plus-year-old patients who get 3 eggs, 3 embryos, 3 blastocysts, 1 normal, and they do another cycle, and that is usually somewhat predictive. If you make good blastocysts, you often will again, even with low numbers. And I think you don't know what the potential is until you see it. So I prefer to see what the embryos can do. If you see a cycle where they make no blastocysts, then again, you have an individualized discussion. Maybe it was just a bad cycle. Do we try again? or do you want to take this approach of, let's see if they do better in your body? But I prefer to see what the embryos do and not prejudge that because you're older or have a low number, you're not going to make blastocysts. I think many of those patients do, but that's another discussion.
Dr. Paulson?
Well, I was just pleased beyond measure at the fact that Dr. Forman actually quoted my math study, which I have never seen anyone else quote anywhere. So, but I would point out that it is just a formula. That's not data. That's just data analysis. And he showed you how if you have a 15% aneuploidy rate, 1.5, that you have about a 3% loss of potential implantations, right? So that means that if your aneuploidy rate is any higher than 15%, that is the percentage of embryos that you lose. So if you have a 30%, 30 aneuploidy rate instead of 15, you're now losing those additional 15% implantation. So even using his numbers, that would have been a 18%. We went from 3%, now you're up to 18%. And if you have a 50% aneuploidy rate, which is what they have, then of course that's 35% more than his baseline 15. So there's your 38% loss rate. And the losses really are very high. And it is not okay to be throwing away 50% of embryos in a patient who's under the age of 35. I am so glad that we agree on that. I don't want to counter what he said. I want to totally emphasize it. And the fact that that formula can be used not just to say how much you lose, but what you don't lose. And therefore, if you don't meet those benchmarks, how much worse it's going to be.
Well, thank you both. And I think we can go to the poll to see if anything has changed from the onset of this very, very exciting webinar. Do you recommend PGT-A for all patients, only women above 35, only for gender determination, or only for patient request? I think at the outset we saw a lot for women above 35, and it's almost the same. So people are still focusing on PGT-A in women above 35. Okay. What about advanced paternal age patients? We didn't talk too much about that. There is not a lot on that yet to truly compel us, but would you do it just because of paternal age? We know that in that age group, advanced paternal age, higher rates of miscarriage, infertility, preterm birth, autism, schizophrenia, and birth defects. So what would you all do about that?
Well, Eric said it, right? I mean, in fairness, Eric said there's no data on paternal age. So those that are using it, yeah, PGT-A will not pick up autism spectrum.
Oh, sure. Right. So majority are not doing it because of that. So what about CVS and amnio? We didn't talk much about that. I know that it's advised by ASRM to be doing that for patients who've had PGT-A. The audience initially said 50-50. So let's see how they feel after this. Are you both in agreement that patients should be at least offered, irrespective of age, if they've had PGT-A?
Yes.
I think it's looking for different things, and I think it's pretty accepted to offer to everyone, even young patients.
Yeah, still 50, still maybe a little bit higher, but almost 50-50. Okay.
Those that don't advise it must not have seen an error. Eric, have you seen where you transferred a male embryo and it turned out to be female, or vice versa? You transferred a female embryo and it came back male?
I've seen all kinds of things in there. I mean, there's papers on discrepancies. Yeah, so it's not perfect.
Yeah. What about mosaic?
How can you not offer that? Yeah, I don't understand how you would tell somebody, no, don't worry about it, you're going to be fine.
Right.
I mean, that you can pick up with NIPT, but yeah, I've seen, seen all kinds of things.
So with mosaic embryos, just low level, low and high, or no? So still majority is low level, but there are a fairly quarter of the population is doing low and high level. Any comments from either of you?
Can we switch to intermediate copy number, please?
Yes.
Yes.
Right. The mosaic has not been verified. When you transfer mosaic embryos, those babies are not mosaic. So it's isolated placental mosaicism in 1.5%, right?
I think there have been more mosaic babies born from euploid embryos. than from mosaic embryos. But yes.
Okay, here's one that is very profound. Is that would we ever transfer an aneuploid embryo? And while we're waiting for that, do you on the panel think that there's ever a place for known aneuploidy results to transfer outside of IRB protocol?
Yeah, I mean, I think those are patients that, you know, if you counsel them up front, would probably not choose to do PGT in the first place. So if they're appropriately counseled and you think, again, that the potential of those fully aneuploid embryos is so low and the risk is high, I don't transfer them. But again, they're not automatically discarded.
If the true aneuploidy rate is 15% and your lab is giving you 50%, then that means that a third of the ones that are labeled as abnormal are actually normal. So it really depends on the lab, and I would now support what Dr. Forman said, is you have to know your lab and you have to know your aneuploidy rate in order to be able to make a rational decision.
Again, one thing I would say though, that 15%, again, remember that the best quality single blastocyst may not be the same as the, you know, lower quality, you know, third embryo out of the group. So Dr. Paulson lumps them all together, but they're not all the same.
Not the same. I agree.
Well, and the majority, 2/3, are not going to be transferring aneuploid. So I can't thank you both enough for the generous use of your time, your
Thank you.
outstanding review of the literature, your insights, and as well as your continued invaluable contributions to our literature. Thank you so much for being a part of this. And I want to also thank once again Sarah Ramaya for her tireless efforts at putting all of this together. Please remember that next week we have an outstanding journal club sponsored by ASRM on PGT. So thank you all for attending this valuable webinar, and until next time, take care.
Bye.
Thank you, Dr. Trolice, for moderating such a fantastic session. And thank you to our panelists for bringing such an important topic up for debate and discussion. And to the attendees, thank you for joining us. The session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.